I'm going to tell you a little story about how we got to the point of doing a collaborative population-based versus practice-based reminder recall intervention to test these two methods for increasing immunization rates in young children. So first of all, efficacy, effectiveness. Immunizations are basically second only to clean water in terms of the number of deaths and morbidity they prevented. And this slide just makes that point. If you look over on the right, this is the percent decrease in these common childhood diseases since after the advent of vaccines. So the Healthy People 2020 goal is to increase the proportion of children 19 to 35 months who receive all routine recommended vaccine, and their target is 80%. It's kind of hard to believe we're not there given the incredible efficacy of vaccines, right? Where we are is in the United States, about 73% overall. In Colorado, we were 68%. So definitely some room to go. So why is this? I'm not going to go through all these barriers that have been recognized not only through our research but through many researchers. Just to make the point that if you were going to think about how were you going to better implement immunization delivery, you'd have a lot of issues to deal with. So you could focus on any of these areas. And, you know, some of them are very tough to tackle. Some of them are more straightforward. We chose, because a lot of these issues actually affect small numbers, not huge numbers, we chose to take a very pragmatic approach and try to reach the most number of children we could and not specialize too much. So we took a highly pragmatic approach. So what's been shown to work before in immunization delivery based on strong evidence is reminder recall. And this is recommended, probably the strongest recommendation from the Community Preventive Services Task Force. So reminder is notification to inform patients or parents that their child is due for a vaccine, and recall is reminding them when they're already overdue. And it can be delivered in a whole lot of different ways: mail, phone, autodialer, text, email, etc. But in the past, it's been conducted at the level of practices, using usually practice-based systems. And there have been, just in terms of the evidence, this is going to take a sharp turn here, so I want to make sure you get this. There have been 47 RCTs that have been included in Cochrane review that show effectiveness of reminder recall. However, when we reviewed lots of these, and we did a number of these trials that are part of this, when we reviewed these, 35 out of 47 were actually done by research teams coming into practices, and none of these trials measured sustainability. So lots of effectiveness in the real world, but not necessarily so real world. So our study team had already spent years studying and trying to improve practice-based reminder recall efforts. We had measured effectiveness in different settings, in different populations. We'd done a lot of qualitative work to look at the barriers. And basically, what did we learn? It's really tough to implement reminder recall, even in highly motivated practices that have access to a centralized immunization information system, what's more commonly known as a immunization registry. And there's lots of barriers to implementation. And I think the top three that we felt were almost universally there were competing demands. Primary care practitioners are so busy they can't add two more keystrokes, as you said, not two more keystrokes. There were inadequate systems to deliver the intervention and usually inadequate training. So you might get somebody trained up and then they left the practice. And then there were cost considerations. At the same time, this is actually a typo, national data suggests that 16% of physicians were doing reminder recall nationally. So after many years of work, we decided to learn from implementation failure. And we thought it was time for a new idea that accomplished what practices wanted for their patients, but facilitated implementation and sustainability. So what did providers want? And they wanted lots of things, and patients wanted lots of things. I'm just going to bring this down to a couple of very actionable items. We did a lot of surveys and qualitative interviews. Providers wanted to do reminder recall for their patients, but the majority thought they just couldn't. It was not feasible. So there was a mixed feeling there. The vast majority, 85%, were okay with public health taking a major role in this. Only 15% were not okay with that. What did parents want? Roughly half preferred for their provider to do reminder recall, and half didn't care if the reminder recall came from the public health department or even preferred the public health department. However, very few parents were, again, adamantly resistant. So this was our implementation idea, a centralized and collaborative approach. We would make use of the state IIS to simplify and centralize reminder recall. So the algorithms that the IIS has would determine who was not up to date. The IIS can generate mailing addresses or lists or even postcards. The state public health department would conduct the reminder recall centrally. They would push the button. This would reduce the burden on practices, and it would potentially reach children who are not in a practice and therefore would not get practice-based reminder recall. And in order to be responsive to the provider and parent desires, the reminder recall messages could come from both the practice and the public health department, so that there would be that endorsement of the practice. In addition, the practices could actively collaborate with the public health department by updating addresses and therefore decreasing costs. So that was our plan. And in development of this collaborative intervention, we did surveys and qualitative data. As I said, we also had advisory committees of parents and providers who helped us look at the qualitative data and survey data and make some decisions. So I just want to highlight the principles that we used in developing this approach. First of all, we designed the intervention with sustainability in mind. And I guess you could say designing for dissemination as well, same thing. We wanted it to be low burden. We wanted it to capitalize on existing technologies and systems so that it would be easy to disseminate widely. We wanted to design it for scalability. So this kind of system, if it worked, could be used in another state. It could be used across the state, so very scalable. And the intervention was guided by the preferences of providers and patients, not everybody, but the majority. We did, as I said, try to get the endorsement of the trusted professional, and the letters or reminder recall messages did have some information about immunization, so there was some knowledge transfer involved there. And we had a lot of collaboration between stakeholders to increase the efficiency and decrease the costs. The other thing we did was iterative testing with the stakeholders. Midway, at the end, several times. So we did make some mid-course corrections. The goals were highly pragmatic. We were trying to increase rates for entire populations of children with the highest level of efficiency, lowest cost, and without undermining the concept of the medical home. And this required a highly collaborative approach involving our main partner was the state public health department, but also the local public health departments. And in order to capture that, we involved the Association of Local Public Health Organizations, or CALFO. The local public health departments, we attended a statewide meeting, presented this to them. We got a lot of feedback. We did key informant interviews. Not everybody was happy, but the majority were. We involved the Children's Immunization Coalition and local primary care organizations. And we had, as I said, the Parent Advisory Committee was selected with the help of providers. So in evaluating this, we chose a very pragmatic approach. The population included all children in identified counties. So that kind of heterogeneous population is consistent with a pragmatic trial rather than a classic clinical trial. The settings, again, were very heterogeneous, all urban and rural counties and all primary care providers. In terms of the evaluation, I'm not going to go through this, thank goodness Russ did, but this is the REAIM evaluation framework that we did. And I just want to highlight, the important, I'm going to show you a few results, and I want to highlight the importance of reach in this study, the concept of reach. If we had not measured reach, we would not have understood what this study did. So these were our objectives: to directly compare a collaborative population-based approach with a practice-based approach, and I won't go into the methods we used in the practice-based, but suffice it to say it was very pragmatic, what you might do for entire counties in terms of encouraging them. So here's the reach. In the practice-based counties, because 10 practices did reminder recall out of 195, the greatest potential reach of that intervention was 5%. Whereas in the population-based, and this was an accurate reach because we knew exactly, we corrected addresses, et cetera, the reach was 85%. So that's the answer in this trial, is the reach. It's very important, obviously, that we looked at that. So this is I'm only going to show you two results. This is the percent receiving any vaccine within 6 months. On the left of the population-based, 32% versus 23% in the practice-based, with an absolute effect difference of 9%. Excuse me, I thought I got rid of these slides. Okay, wait. Cost. Per child brought up to date, $17 in the population-based. Per child, who received one vaccine, $10 versus $38. You know, this is not my latest slides, but we'll get there. Okay, so lessons learned. I think the biggest lessons were to design implementation interventions with sustainability or dissemination in mind from the get-go, and to use a poker analogy: know when to hold them, know when to fold them, know when to rethink the plan. Sometimes you got to start over and say, this is not working, I want to do something else. And thirdly, listen to stakeholders and recipients of the intervention and continue to adjust iteratively. Thanks.